Hi. Hi there, everyone. Welcome to our Project Echo, Best Practices for Aging Care. My name is Pam Yankila, and I'm the Director of Research and Evaluation at the University of Louisville Traeger Institute. And we present our Project Echo in partnership with the Kentucky Coalition for Healthy Communities. We just want to offer some engagement strategies. We ask that you keep your video on if you can. It just helps create trust among our learning community and get to know one another. We do ask that you mute yourself. If you want to share a comment or have a question, please go in and raise your hand, chat, or unmute. If you're having difficulty with your sound or your video, please just go in and check on the arrow right next to your microphone or video to test your system. We do ask that you add your name and your organization. And look at me, I don't even have my organization on there. The way you can do it is if you look at your video square, there are three little dots in the upper right-hand corner. You can click on those three little dots and a dialog box will come up and you can hit rename and you can add your organization, as I am doing that right now. There's another way you can do it too, is you can go to the participants, which is in the lower middle portion of your screen, and then click on participants, find your name, and then go on and click on more, and you will see rename, and you can add your name, your pronouns, your organization, all those things. So if you're unfamiliar with the Traeger Institute Republic Bank Optimal Aging Clinic, our mission is to help individuals optimally age throughout their lifespan. We are a workforce development hub, so Project Echo is part of that workforce development hub. So we train interdisciplinary teams to focus on helping people optimally age. We have several grants that support that, and our Project Echo is supported by those grants that infuse geriatrics into primary care and behavioral health into primary care and paraprofessionals into primary care. We are trying to engage in practice transformation. We are thinking about where is it that we receive our primary care, whether it's in an outpatient clinic or in an emergency room or a nursing home, and trying to transform our those clinical spaces to be more age-friendly and trauma informed. We also are trying to transform our community. So many of us spend most of our time in the community, not so much in a healthcare space as we age. And so the idea is that we're also trying to change our communities. So we're trying to infuse all this information about how to optimally age in our communities as well, so that people that are, as you know, patients and clients are the center of a bullseye, that we're trying to change the minds and the skill sets and the behaviors of the healthcare professionals that work in those clinic spaces to have a different idea about positive aging. And we're also then trying to change our systems so that our systems support the way it is that we present and act and deliver care. And then we're also trying to change our communities so that when we spend time in our communities, those communities are also age friendly. And we do our Project Echo in collaboration with the Kentucky Coalition for Healthy Communities. And I'm going to pass the mic to Mona Huff, who's going to share a bit about the mission of that coalition.
Thank you, Pam. Good morning, everybody. And again, welcome to our ECHO KCH meeting. And our KCHC stands for Kentucky Coalition for Healthy Communities, as you can see. And our job is to help support the systems in our rural areas, as well, of course, Jefferson County through our Traeger Institute for our older adults. And we do that by partnering with existing local coalitions and organizations. And we offer a lot of education from that perspective. And you'll hear more about that at the end of the presentation. We want to help develop the workforce and concerned community members to empower our communities to become healthier. And that is a really important part of our mission, is that we can be a part of our communities and thus our state of Kentucky becoming a healthier place to live and to work in. So again, thank you for being here, and we certainly look forward to our presentation.
All right. The University of Louisville Traeger Institute and Republic Bank Optimal Aging Clinic is really driven by two frameworks. One being lifestyle medicine. There are 6 pillars to lifestyle medicine, and the idea is to prevent, reverse, and treat chronic disease by using these 6 pillars. The 6 pillars include that food is medicine, whole food, plant-based nutrition, that regular physical exercise is medicine, restorative sleep, avoiding risky substances is medicine, making sure to engage in positive social connection and stress management. Additionally, we are guided by the 4M framework. And the 4M framework was developed by the Institute for Healthcare Improvement. And the idea is to focus on what matters most to the individual, making sure that the medications that we are reducing any risky medications for older adults and deprescribing when possible, making sure that the medications we are on does not interfere with what matters most. We also want to make sure that we have daily mobility goals as we age and that we are making sure that we are focusing in on our mind and our mentation. So thinking about mind and mood and looking at delirium and depression and anxiety and our cognitive health as we age. So here is our schedule as we are moving forward. We are on May 15th, which is pulling back the sheets on older adult sexuality. On June 12th, we have nutrition and social connection, the power of shared meals. And July 17th, we have comprehensive management of complex voiding dysfunction. So you can take a picture of that. If you sign up for our Project Echoes through registering in iEcho, you have access to all of these. If you're unfamiliar with the Project Echo platform, Project Echo has been around since really the early 2000s, and it was founded by Sanjeev Arora, who's an MD. He's a hepatitis C expert, and he was having patients come 200 to 300 miles to come and see him in the office, and he really felt like he wasn't creating greater capacity to see patients, and that he was kind of failing in that regard. So what he decided to do was develop this telementoring platform called Project Echo that really pushes out knowledge and skills to individuals. Instead of moving the patients, we're actually moving the knowledge. And the idea is to build that capacity at a local level. So Project Echoes in general have case-based learning. In our space, we're looking at interdisciplinary team-based care so that we can move from unidisciplinary care to more transdisciplinary care where we work together and have an understanding of all the different disciplines as we work with our older adults and across their lifespan. So you can receive an attendance certificate. You can receive a certificate for 1.5 hours for today's session by completing the evaluation at the end of the session. And community health workers and social workers must complete the evaluation if you're interested in receiving continuing education. Our community health worker continuing education is approved by the Kentucky Office of Community Health Workers, and we're able to provide 1.5 CEUs for certified community health workers. And Brushy University is providing the CEUs for our social workers, and that's approved by the Kentucky Board of Social Work. And to learn more about that, you can look at the QR code. Today we have our didactic presentation by Dr. Laura Morton, and the title of the presentation is Pulling Back the Sheets on Older Adult Sexuality. And before we hand her the mic, I'd like just to do a brief presentation and a bio on Laura Morton. So Laura Morton is a professor of geriatric medicine in the Department of Family and Geriatric Medicine, a director of the Division of Geriatric Medicine, and the director of the Geriatric Medicine Fellowship Program at the University of Louisville School of Medicine. Dr. Morton is board certified in internal medicine and geriatric medicine. She has a lifelong interest in long-term care and worked as a certified nursing assistant during college. She maintains an active practice, delivering care to patients as medical director of several local facilities. We're so excited that you're here, Dr. Morton. Thank you so much for being here.
Well, thank you for that warm welcome and introduction, and welcome everybody. And I'm really excited to talk to you today about older adult sexuality. And this is a topic I think that can be a bit polarizing sometimes. Some people want to pretend we don't want to talk about it and pretend it doesn't exist, and others are really excited. So I'm very passionate and look forward to your participation and any questions that you may have as we go on this journey together. So our learning objectives today, we're going to talk about the myths surrounding older adult sexuality. You will be able to understand what older adult sexuality really looks like and changes that happen with aging. And lastly, we'll talk about ways to talk about this topic with older adults and their caregivers. And Justin, if you will pause the recording, and then go on to the next slide. And so we'll start out with a recording. Thank you. So I like to so this is that's a movie clip, and um it's a wonderful movie. But as you can see there we're here today to talk about sex. And what I always tell people is really sex is everywhere. It's all over the media, it's all over social media, it's in movies, it's in TV. But in the healthcare area of the world, we tend not to talk about it. And I think that's my goal, and that's my hope, is that doing these talks and encouraging others to really feel comfortable talking to other people about sexuality, because it is a part of life and we should be talking about it in the healthcare setting, whatever our role is on that team, because it's so important to people's lives throughout the aging spectrum. So this slide here shows you some of those examples of where we see sexuality in the media. Some of you may be familiar with some of these people on here. How to Build a Sex Room was on HBO, I think, and on Netflix. The bottom right corner is Dr. Ruth with Hugh Hefner. And then the top right is Sue Johansson on The Tonight Show. And she used to talk, she was an older adult who talked a lot about sexuality and would come on and TV, and was very entertaining, to say the least. So again, we talk about it in a lot of different places, and I'm trying to encourage everyone to talk about it in healthcare as well. So next slide. All right, so I'm going to ask for your participation here. So what comes to mind? And you can type it in the chat box, but what do you think about and what comes to mind when you think about older adult sexuality? What are some things that pop up in your head? People don't want to talk about it. Medication needs. My wife talking to her mother about safe sex when she started dating. That's great. Desire versus capability, stigma, desexualizing older adults, outdated ideas, rarely discussed in the doctor's office. You're right. Families don't understand. Disability considerations. These are great. Helping my grandparents find assisted living, and they did not want to be in it because they still chase each other. STDs. Older people want to talk about it with especially younger people. Okay. Great. Great. These are all really good comments. So keep all this in mind as we go forward. So some myths about sexuality in older life and later in life, and I think you will touch on some of that. Sometimes it's seen as a laughing matter. Some people think it's really gross or disgusting and don't want to think about it, don't want to talk about it. I can't believe, grandma or grandpa would even want or even have a thought about any kind of intimacy or sexuality. Sometimes you think of the dirty old man or the old spinster. And there's the myth that older adults just aren't interested in sex. And I will tell you, so I teach at U of L, and whenever I have this, to give the kind of topic about older adults and talk about it with our learners, I get a lot of varied reactions. And, some of these people are in their 20s, maybe their 30s, and I always ask them if they have a reaction and say, well, do you want to have this as a part of your life in 40, 50 years? And I think that's the best way to really frame it, because it makes people think, maybe I should reconsider how I'm thinking about it. And here's a little cartoon. It says, Grandma, Grandpa, don't tell me you. And it's a study showing that seniors are having sex. So again, this is a myth. We'll go on. So why is this such an important topic? And I am sure if you all are here and taking care of older adults, you know this. But in the past 12 months in this study, in sexually active people from age 75 to 85, 54% had sex 2 to 3 times per month, and 23% reported sex at least once per week. About 70% of men over the age of 65 remain interested in sex, and about half of women over the age of 65 express interest in sex. And the current level of sexual activity generally correlates with past sexual frequency. So I always tell people that. So in people who were very active in earlier in life are going to continue being active. And this is important as people move through the care continuum and as they age, that we remember that. Most older adults do desire more activity than what they have, and lack of partners and privacy as people get into different healthcare settings are significant obstacles. So here's a couple of models of the sexual experience, and I'm going to look at this from a very high level. So there's going to be more things on these slides than I want you to really pay attention to. So when we think about the traditional model, we think about a very goal-directed sexual experience. It's very linear. We start at one point and we end with orgasm. And that tends to be more of what we see earlier in life in younger adults. But as people age, the way sexuality and the sexual experience happens changes. And there's another model of sexual experience, and this is Bassen's. It's a nonlinear model, and it was traditionally described by Bassen as a female sexual response cycle. But I would argue that it's more consistent with the older adult sexual response cycle because it isn't all about that goal-directed experience. Things can start in one point, it can be more about intimacy, emotions, and then the physical part, and it can be circular. So I think that's really important to remember that it does change across our lifespan and how we experience sexuality and intimacy. And so that's really important as we talk to older adults about sexuality. So as we age, there are changes that happen in our sexuality, both physically and from a psychological standpoint. Women live longer, often without a partner, or they have an ill partner. Some women actually will become more sexually active with aging. In the past, they were concerned about pregnancy, and that's not an issue. And so you see that there may be an increase in sexual activity related to that. With aging, there are some physical changes that we see. There's decreased blood flow to the vaginal area and decreased lubrication. As women get older, they still can have multiple orgasms, but their orgasms may not be as strong and their contractions may be less frequent with orgasm. And then after having a sexual experience, they return more rapidly, their bodies, to a non-aroused state than they did when they were younger. Menopause, we can't have this conversation without at least touching on menopause. Menopausal symptoms do really impact sexual function. Hot flashes, and I'm sure that there's probably some of us on here who may have had or be having those experiences. And what you see is this heat wave, flushing, sweating, palpitations, anxiety, sleep disruption that can happen, and mood changes. But those hot flashes do respond to estrogen, and if you've seen anything in the news, there was previously a lot of warnings about using estrogen replacement therapy, hormone therapy in older females, and concerns, but those warnings have been changed and taken away. So again, if you have someone you're working with that's having a lot of menopausal symptoms, they need to talk to their provider about that because hormone treatment is helpful. The second thing that we have to talk about is urogenital atrophy, which is now called the genitourinary syndrome of menopause, or GSM. And what that means is that we see as people don't have estrogen, you see atrophy and kind of lessening of the tissues of the vaginal area. So you can see physical changes. It's gradual, it worsens over time. You get vaginal dryness, soreness, and you see pain with intercourse in about 30% of women. So these are some symptoms that do impact sexual function. How do we manage sexual dysfunction in women? We always want to say non-medication therapy, which goes along with our optimal aging and doing lifestyle medicine. Things that we can do are sex and couples therapy. And again, you have to look for people who have an interest in this subject matter. If you're having a lot of physical things, pelvic physical therapy can be a real godsend to people, can really help impact that pain with intercourse, or if someone's having trouble with prolapse or weakness, can be very helpful. Psychodynamic therapy, lifestyle changes, again, diet, exercise, all important, improving the body image, and using lubricants. And again, I already spoke about the hormone therapy with estrogen. So, what happens in men? So, men experience physiologic changes as well with aging. You see a gradual slowing of the physical reaction time. Erections generally become less firm, but they do maintain the capacity for intercourse. There's a lower production of semen. Ejaculation is less forceful. Erections subside much more rapidly. The refractory period is prolonged. Infertility may diminish, but usually in the mid 70s. So that's always important if you're working with any older males that happen to have younger partners, because pregnancy is still possible. So just a reminder. With males as well, we see a decline in sexual activity with aging. It's usually associated more with declining health than increased age. Sexual interest does decline less than sexual activity. But what we see is if there's a decline in intercourse, there's actually an increase in other forms of sexual contact and intimacy. So you may see more kissing, caressing, oral sex, or masturbation that occurs. Erectile dysfunction. So I think an important thing, aging does not produce erectile dysfunction. I think that's something we need to hear. I think there's so many commercials. I know everybody on here could probably think of multiple commercials on the top of their head about erectile dysfunction. And to make the diagnosis of erectile dysfunction, it has to occur. So erectile issues have to occur in greater than 25% of sexual encounters with the same partner. So if you have somebody who has multiple partners and is having trouble, you can't really diagnose it. It has to be with the same partner. The probability of erectile dysfunction is 40% at age 40 and about 70% at age 70. So it is much more common. The most common cause is vascular disease. So you think of atherosclerosis or narrowing of the arteries, or it could be venous leakage, which can be trauma related, or it can be from Peyronie's, which is also, you see a commercial for that nowadays too. The second most common cause is neurologic. So thinking related diabetes, if someone's had a history of stroke, or if they've had surgical procedures, and that's commonly occurs with prostate surgery. So if somebody who had an enlarged prostate or had prostate cancer, we see a lot of issues related to that and erectile dysfunction. Other causes of erectile dysfunction that happen are diabetes. About 50% of patients with diabetes report erectile dysfunction within 10 years of their diagnosis of diabetes. So again, this is a good motivating factor to help people with working on their diabetic control, whether it's through dietary changes and exercise as well as the medication. So this can be a motivating factor. Testosterone, there is the role about testosterone and low testosterone level in erectile dysfunction is a bit controversial in the literature. There's not a clear answer at this point. There are some medications that can contribute. We think about psychogenic or the widower syndrome. So some people, if a male lost his spouse and then starts dating and attempts to have a sexual experience with a partner, they may have a lot of angst and underlying psychological concerns that leads to the erectile dysfunction. So we think about that as widower syndrome. There also are hormones like thyroid disorders that can contribute, and then chronic alcoholism can lead to erectile dysfunction. So how do we evaluate this? And I put this up here because I think any team member who's helping take care of older adults can really ask some of these questions and then encourage people to go talk to their healthcare provider, right? Try to help connect them with the people that can help with their concerns. So we ask about sexual history. How long has erectile dysfunction been going on? How are their erections? Do they have erections when they're not trying to have intercourse? What are they like? And do they have any differences in different partners? What about things that have changed in their lives? Did they have the death of a spouse, a child? Have they lost a job? Have they moved into a facility. Those are things we want to ask about. What medicines do they take, and what medical conditions do they have? And then remember, I always put this, prevention is always the best way we can do it. So there is an inverse association between physical activity and erectile dysfunction. So the more active you are, the less likely you are to have erectile dysfunction. So again, another plug for exercise. And when we talk about treating erectile dysfunction, there's multiple agents, and it's kind of a stepped treatment option. So first, you start with psychosocial. So if there's any underlying psychological issues, you want to get counseling to try to help with that. Vacuum erection devices, which are commonly referred to as penis pumps, constriction band devices, or oral agents. And these PDE5 inhibitors are the ones you all see all the commercials for. And if anybody ever says that they were given one of those, Viagra or one of them, and it didn't work, you have to have stimulation for efficacy. I've had a couple of patients that said I took it and waited and watched the time and nothing happened. And they were just waiting for things to magically occur. So again, you have to have some stimulation that goes along with taking the medications, and you want to try to give it a good try. So attempting it more than once before saying that medicine doesn't work for me. The next step would be doing injections or suppositories in the urethra, and a lot of males really hesitate to do that. But again, this is the next step up, and the most significant and invasive step would be to do penile prostheses, and that's more expensive and obviously has its own risks. So, what are some common concerns about older adults about sexuality? And there's some medical things that people may ask about. Um, what to do. So if someone had a heart attack, so an MI, they can usually resume sexual activity about 8 to 14 weeks. And the way to do it is, can you walk a few blocks without having chest pain or shortness of breath? If people are still having chest pain, that's where it's helpful to talk to someone about position changes. What uses the least amount of energy? So again, talking to provider, whether it's getting connected with an occupational or physical therapist that's comfortable with the topic, because there are things that we can do for those people who want to maintain sexual activity, but have underlying medical conditions that may limit it. With hypertension, high blood pressure, there's really no restrictions unless the blood pressure is really high. Arthritis, so between the hips and knees, and you see a lot of hip discomfort with intercourse and sexual experiences, and positions can be very helpful. Position changes, as well as using some sexual furniture. So some furniture that may help with positioning. So again, things that you can talk to someone about. Incontinence and Parkinson's disease are other concerns that people have. We also have what's called pelvic steel syndrome, and this produces erectile dysfunction, and this is related to some of that underlying vascular disease or the narrowing of those arteries. And what you see is when a male is thrusting, that the blood flow goes to the buttocks and not in the penis anymore, so they lose their erection. And so this is where talking about position changes is really important. If someone's had a history of stroke, they may have erectile and ejaculatory difficulty, and in females, you see difficulty with vaginal lubrication. Again, so these are things that, just to be aware of if people have these conditions, that it can impact their sexual experiences. And again, talking about lifestyle, always nicotine, so smoking, whether in whatever form, can lead to vasoconstriction, which means narrowing of those blood vessels, which can lead to erectile issues. So another motivating factor, hopefully, for people to stop smoking. Alcohol really does impact erectile function, so very important to encourage moderation or cessation. Pain medications, opiates, antihypertensives. Used to be that everybody thought that beta blockers led to erectile dysfunction. That's not the case anymore. Antidepressant medications are very commonly associated with decrease in sexual interest and experience. So you have to talk to your prescriber if you're experiencing symptoms. And then over-the-counter medications like antihistamines can cause a lot of problems as well. On here, I practice a lot in the nursing home. So here is a cartoon. It says, well, if you service dinner at 5 p.m., how else do you expect us to pass the time until bed? And if you look closely at this cartoon, and this is always the thing that kind of amuses me, yes, you're highlighting it while the person behind the door. So I'm not quite sure what that's about, but anyway, it's a pretty cute little cartoon. But older adults in congregate living, it is a challenge. What we see in older adults in congregate living is that lack of privacy. Sometimes you see a lack of partner, so you may see more solitary sexual expression. And then staff members in those settings may view sexual expression negatively. And it may go back to some of those things you all added in the chat earlier about what they think about when thinking about older adult sexuality. And this is an old internet meme that went around some years ago, but whatever happened to our sexual relations? I don't know. I don't even think we got a Christmas card from them this year. So anyway, just a little humor here. So I will lead into the next section, providers, patients, and sex. Oh my. I think this is a really important topic for this group, especially. Provider-patient interactions. For 68% of the women in this study, sexuality had never come up during an office visit. And for me as a physician, as a geriatrician, it's just horrible because this is where these conversations should be happening. Older women were less likely than younger women to have ever had the topic of sex raised. When sex was brought up as a topic, older women were twice as likely as the physician to have raised the topic. But the people in the survey reported it was easier to discuss their sexual concerns if the physician brought it up. So again, it speaks to how, we should be talking about this just as a part of our routine care. What are some barriers to discussing sex? So patients generally in the survey had wanted to talk to a provider of similar age and sex to minimize embarrassment. And we know that's not always possible. But even with that in mind, 97% said they would talk about sexuality if the provider had initiated the discussion. 80% also said they would be willing to come back for an appointment dedicated to that topic, which is really important. As we all know in the healthcare system, you a lot of times, unfortunately, get about 10 minutes, which makes it really hard to have these conversations. So I think it's really important that we remember, hey, maybe we can just ask for a special appointment to talk about it. Other things. So, why are providers reluctant to talk about or start the conversation about sex? They may believe those stereotypes we talked about earlier that older adults have no interest in sex. Some people are worried that patients might be offended if we bring that topic up. I will tell you, a lot of physicians, NPs, PAs really have a lack of confidence in their own ability to have these conversations, right? Can be a touchy subject. It can people bring in their own lenses, of course, and their own experiences. So that can lead to a lot of uncertainty about how to have these conversations. If the provider appears to be rushed, that can really serve as a big barrier to having this conversation. And if they're obviously uncomfortable when they're having the conversation, right, that doesn't promote that open conversation. And the other thing is if they really don't seem like they're interested. And again, that's where I always tell people whenever I do talks, if you have a provider of whatever kind that doesn't want to take an interest in what's important to you, that's where you have to look at if it's a good fit. Provider-patient relationships are a lot like other interpersonal relationships or friendships. So you have to have the right fit. So always important to keep that in mind. And here's this older adult, this couple in bed, and she asked, "Did you remember to bring a condom?" So, cannot do a talk without talking about HIV and AIDS in older adults. Someone mentioned STDs in the chat. Common misconception is that older adults aren't at risk for HIV or AIDS because they're in stable relationships or they're not sexually active at all. And this is the newest data, just looked earlier this week, but 19% of individuals over the age of 65 have been tested for HIV as of 2022. That is low. Older adults are more likely than younger people in the United States to have late-stage HIV at the time of diagnosis, which probably goes back to that low numbers of testing. And Medicare will actually cover annual HIV screening if there are risk factors. So again, you have to have the conversation to start talking about testing, but it's really important. Sexual transmission accounts for about 60% of HIV cases in older adults. Some of it could be from drug use, but it's sexual transmission in most cases in older adults. As of 2022, which again is the most recent available up-to-date statistics as of earlier this week, according to the CDC, 54% of people with HIV in the US are over the age of 50. 15% are 65 and older. And as our population ages, we're going to see more of it. There's more treatments so that people live with HIV much longer than 20, 30 years ago. So we will all be taking care of these patients. HIV risk factors for older adults are similar to those for people who are younger. But again, like we talked about, they may not get tested as frequently. People age 50 and older account for 16% of new HIV diagnoses. So again, just remember we need to keep this in mind when we're talking to patients. And this was in New York City, and they did a campaign several years ago, but these signs would be put on the side of bus stops. And it said, when it comes to sex, age is not a condom. So again, we have to remember this. Go ahead to the next slide. And I want to play this. This is yet another video clip, but this one is available on YouTube, so go ahead.
I just sit right here.
Let me show you something. Party, party, yeah. Let's get this party started. Party, party, yeah. Let's get your body rocking. Party, party, yeah. Let's get your body moving. Party, party, yeah. Let's get it on. Party, party, yeah, yeah. Party, party, yeah, yeah.
So it's a really great resource. And we just need to keep in mind that people have the same risk factors. And we tend not, because we're not having these conversations in the healthcare setting, we're not talking about safer sex. What I always encourage our younger doctors in training and nurse practitioners and PA students that I work with is that this should be a part of our routine hold on just a minute. There is a door knocking. Please ignore that. So anyway, just always, life interruptions here. But you want to have this as part of routine healthcare. So if you have someone coming in for a Medicare annual wellness visit, if you have them coming in for their annual exam, you want to have these conversations. And if we make it more routine, then it takes away some of that tension, some of that stress. And I always encourage people, all members of the healthcare team, practice makes perfect. So the more you have the conversations, the more comfortable you will be, and the easier it is. So please, here are some resources. And my last thought before we move on to a case is to talk about sex. So that's my thing I want you all to walk away with today. Hopefully the song Let's Talk About Sex gets stuck in your head and you think about it as you go forth and take care of others because it is such an important topic.
Thank you so much, Laura. We're going to be doing a case in a little bit, but any comments, any questions for Dr. Morton? You can put it in the chat as well. I don't know if there's anything in the chat yet. I can begin our conversation. So, my comment in the chat was that, doctors never talk about, they don't ask you the question and that kind of thing. And that it comes up mostly in, urology appointments and gynecology appointments, but not so much does it come up in other places. And, I've seen a lot of the data through our Medicare annual wellness visits, and there's one question on sexual health, and it's, do you have problems with, your sexual health, yes or no, something like that. But I think that there's nothing added to that question. So people don't, think about all the things you just went through. So, what would be, and the other question is, so one question is basically, how do you ask that question so it's not just, a very simple, no follow-up, no getting the person to think about how those things could be related to their sexual health, number one. And number two is prevention. I just feel like there's no conversation related to prevention about how it is that our objective, working in the health field is to help people, if possible, to prevent. And that, I'm noticing that, here we are at the Traeger Institute, we are trying to infuse conversations about cognitive health and doing that in a more intentional way in our annual wellness visit. And because I think cognitive health also is a kind of a taboo topic. And so, and the goal of it is to try to prevent, using the modifiable risk factors if we can attend to those. But I feel like shouldn't that also, shouldn't sexual health also be a place where we talk about, and that it's like part of a consistent conversation through over time to help people optimally age, and how can we have that prevention conversation?
Well, those are great questions and comments. I think I'll answer the second part first. I mean, I really think that, I talked about those risk factors. So, alcohol use, tobacco use, and lack of exercise. Those are all really things that can impact sexual function if we're not doing them, or if we're using alcohol and other drugs. I didn't talk about other drugs like cocaine and meth and heroin, but those things also impact sexual function as well. And I think just normalizing it, making it a part of what we do when we do our annual visits. Like you said, I think, how do we ask the question? So ways that you can talk about it with older adults is really saying, a lot of my patients, as they age, have some concerns or may find that sexuality and sexual experiences are not like they were a few years ago. So, how is it for you? How is it for you and your partner if they're both in the room? I always caution if someone comes with a caregiver, so who may not be related or may be a child, you want to ask first, like, are these is this a conversation I can have with your caregiver in the room? Or is it, that I'd like to ask you some questions maybe without that caregiver present? Because you want to give people that opportunity to have that private moment to share with their provider. I think it's important for the provider to ask follow-up questions. Yes, no, or terrible ways to get answers from people, right?
Yeah, and then the other thing is that do you use these things like when you say, okay, so let's take a look at these risk factors and they affect cardiovascular. Do you also say and sexual health? I mean, do you throw that in too?
I try to, because I find that, sexual health can be a great motivating factor.
Right.
I mean, I will tell you, so my take is if somebody asks for an erectile dysfunction medication, they get the kind of sex talk. So I think that's a great opportunity because it seems like people are very comfortable asking for the little blue pill, right? But that's an opportunity. And if we don't take that opportunity to seize the moment and ask those questions or have those conversations, we've missed it because that person is opening the door. And that's where we can ask more of these questions. Well, what problems are you having? Are you active with, one partner? What does that look like for you? What's important? Because our job is to support you in what matters most and trying to help you maintain function as long as possible and do things safely, or as safe as possible. So I think trying to have that open dialogue is really important.
Thank you. All right, Justine, did you have a question?
Yeah, I've had a lot of experience with this topic with sexuality, but with different and younger populations that are impacted by disability. And the thing that I am most struck by is how frequently women just never thought to ask, and that they think that their sexual dysfunction is entirely normal. And so I think anytime there's a major change in health, whether it's an orthopedic surgery, we're talking about incontinence, are you sleeping well or not? How are your hormones? I think it's really helpful if the provider brings up, has this, whatever the change is, impacted your sexual function at all? Just to broach the topic, because so often, honestly, I'll find women who I work with are in their 20s or 30s, but they're dealing with sexual dysfunction or shame because of incontinence. And so I really try to kind of lead by modeling that you might have taboos about this elsewhere, but I don't want you to have taboos about it with me. And so I just want to bring that up. And that so frequently we talk about the Viagras and the erectile dysfunctions, but just because women's bodies and sexuality is internal, it's not as visible. We just don't talk about it as much. And so I just think it's really helpful to bring it up for the patient or client and not be forcible about it, but just make it clear, I'm available to discuss this if you have questions.
Absolutely. And then really that you're right. And that's a great comment. And just being non-judgmental. And I think that's a reminder, and I didn't say this, but people who have sexual interests that may be less typical. Um, if they had those interests earlier in life, they're probably going to continue them later in life. And I've had several experiences. I'm just thinking of a couple of people been in my congregate living settings where it now becomes a quote unquote problem, right? For the whole team. And I think that's where we have to change the language. These are not necessarily problems, right? These are people's preferences, their likes and interests. And I feel like I spend a lot of my time educating others about like, hey, this, everybody has different interests and we want to support them. And how do we do this from a non-judgmental way as a team? And it really does. It's all about changing the language, the conversation. And I think pelvic physical therapy is so important. There are places in town in Louisville that do it. In rural areas, I don't know. That may be a little bit harder to find because they are specially trained pelvic physical therapists that can help with incontinence and sexual function for both men and women. They actually will do work with both. And I think maybe Pam, you said that the urologist office or the gynecologist office is where these conversations happen a lot of times. So really important.
In the chat, we have a few questions. Let's see. Maybe, what about dementia and the capacity to consent?
So this is a really tricky topic. If we have time to get to the case, we can probably touch on that in the case. But I'll give it just high level. I think it's important to understand that capacity is anything, a physician can determine capacity, but capacity can be specific for certain decisions. Competency is a court thing, so a judge has to determine competency. So I would say I never determine competency, but I can determine capacity. So people could have capacity for sexual experiences and not have capacity for their finances. So I think that's really important to understand as we're dealing with people, that just because people have dementia doesn't mean they can't have sexual experiences, sexual intercourse, they can't have partners. So I think that's really important to think about. And if you have concerns about someone's cognitive function, please refer them to their PCP. Traeger Institute has a great dementia care program and brain health, but please refer them to be evaluated for that cognitive function.
Thank you. We have another question. Any idea if Gardasil will raise the age of giving their vaccine for HPV?
I would
No.
love to see that happen, but I haven't seen any
Not-
movement in that direction yet.
Okay. Bree says, it seems like it would be hard to find therapists that are comfortable focusing on sex in rural areas. Do you have any suggestions for addressing this barrier?
So I think if you have a network or if you have therapist, you would want to probably reach out and just ask, so that if you're a community health worker, you might have several people, but you may have to refer people to larger cities. There's also a lot of more therapy options that are out there. And I think that may address some of those barriers that, hey, we may not have this locally and you may not want to drive a couple of hours, but here is someone who's available online.
Mhm. And then we have a question. Let's see. We had a male patient that was much older than the woman and misused a sexual toy, and the woman was sent to the hospital. Do you talk about the sexual toys or not? Because we deal with different age groups.
So I will tell you that I find this is a very important topic. Uh, Older adults, so because sex wasn't talked about as much, when they were growing up, that even talking about sex toys was not a common thing. Um, I did a talk about older adult sexuality to a group of gynecologists. And it was really interesting because one of the older gynecologists told me a story and shared a story about a patient who came in with vaginal discharge, gone to their PCP multiple times. Oh, got antibiotics, got treatment for yeast, all this stuff, multiple treatments, gets referred to the gynecologist. The gynecologist finally does a pelvic exam, takes a look, And what he found was splinters within the vaginal wall. And the lady then shared that she had been masturbating with a broomstick. And so there was a lot of missed opportunities there, but that story has always stuck with me because, well, first of all, we need to do exams, but secondly, we need to talk about what safer sex toys there are, and there's a lot of them out there. Things can be ordered online, so if people are concerned about going into a store, there are websites that are available, and so I do think it's important to have that, and like talking about not sharing toys and making sure you clean them and what lubricants you can use with sex toys. So yes, I think it's an important part of that conversation with older adults.
Okay, let's see. I think that's all the questions we have in the chat. It's probably a good time to switch to the case. Thank you.
Okay, so I'm hoping that you all will just put a few things in the chat box as we go along. So you provide care to residents with an assisted living facility. One day you're in the building and a staff member comes up to you about two residents that have been spending more time together. That's usually the way people say it. There's usually air quotes involved for whatever reason. And later on, the director comes to find you to talk about this situation. So what's your initial reaction as you get this very vague story? Good for them. I love it. Any other initial thoughts?
Uh,
Great.
Dr. Laura, I'm going to tell you something that I heard from a family member of a woman that she's not paying thousands of dollars a month for her mother to get raped.
Oh my goodness. How did you handle that?
I said that she should probably talk to the director and find out really what was going on.
Absolutely. There's always more to the story,
Mhm.
for sure. So I think all of your thoughts in the chat is really important. And it looks like people are asking about, people are very accepting, but more information. There may be some shock. Trying to explore what it means. So go into the next slide. So the administrator shares that Mr. Smith and Miss Jones have been eating meals together and then going to one of their rooms after meals. The administrator wants your help in managing the situation. Again, a lot of times it's a really vague story. So in the situation, you have to kind of get a little bit more, like you all are alluding to there in the chat. So the more of the story. So Mr. Smith's 83-year-old male, history of hypertension, high blood pressure, diabetes, and he had cardiac bypass years ago, doesn't use any assistive devices, and is widowed but has adult children. Miss Jones is 76. She has a history of multiple sclerosis, has urinary retention, so she has a suprapubic catheter in place, and she does have some memory issues. So she uses a rollator. She was never married, and she has a guardian that's a family member. Okay. So both expressed interest in spending more time together and exploring a more intimate relationship. Okay. I phrased it more generally. So what would you do? I think some of you would ask more questions, I'm going to guess, because that's been a common theme. What else might you do? They are consenting adults. So there is some concern about memory, and one person has a guardian. So that's a little bit of a complicating factor. Talk to family, refer to OT. Yes, and ask more questions. Is she considered capable to consent? Check with guardians and providers. Very good. So you're asking the right questions. Depending on what your role is, it's always good to get them to connect it to their provider who would know more about the medical issues, the nuances. Oh, interesting. We had to prepare the woman in Hoyer lift one on top of the other. That would be an interesting experience, but it sounds like a very supportive place to help. Okay. We can go on the next slide. So you speak with both individuals involved here and really review capacity for sexual activity. There is actually PALT-MED, which is Post-Acute Long-Term Care Medical Association, has a really great document about consent or capacity to consent for sexual activity. So it's pretty detailed, you ask people if they know what would happen. What if you didn't want to? Are you able to say no? It kind of walks through all of that about consent and capacity. If this partner broke up with you, what would you do? How would you feel? So really trying to think through what the consequences might be. And after you figure out if they have capacity, and these two actually did have capacity, so that's through PALT Med, PALT Med, and you can Google that. And then next, after you figure out capacity and what that, if they're able, then ask them about physical concerns, which we talked about earlier. They do have medical histories. One has a suprapubic catheter. So you have to talk about things like positioning. For some people, if they have ostomies, so there are like dignity covers for even ostomies. So that can be very helpful. So if somebody's had colon cancer or had part of their bowel removed, you can buy those to actually cover them up for, all the time, but for sexual experience in particular, because that can be, help provide that dignity and privacy that allows that to not be such an issue in the middle of sexual activity. I think talking about positions, talking about sex furniture, whether it's the furniture, whether it's pillows and cushions and things like that would be important. And again, the gentleman in this case had a history of heart surgery. So you want to talk about, how much activity is he able to do? Does he get chest pain when he's walking across the room? So having those conversations to figure out what can we do. So I'm answering some of the question here, but concerns about sexual activity from a physical or medical standpoint, those are things we have to think about. We talked about the, erectile medications, and a lot of those medications are really, you can't use them with nitrates. And so if people are on nitroglycerin, you can't use them. And so those are things where you want to tell people, take all your medicines with you to your doctor, to your provider, to make sure that they take a good review and look at if any of those would interact and what we can do to help. If we can't use those medications and someone has erectile dysfunction, what are those other treatments that we can use? So really important to kind of walk through that and have an open conversation. If they both have capacity for sexual activity, in this case they did, but since the one had a guardian, we did end up reaching out to the family, to the family member who was the guardian. It was not a guardian it was just a guardian for finances. So it's a little interesting, made aware. I think the initial reaction was like, oh no, 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 but then after some conversation, it was like, well, this was providing quality of life, it was providing companionship, and it was something that both of them were interested in. And so everyone was supportive. I think it's just really important to go through this process, and it helps educate the staff, the administration, everybody, because you really do have to educate the whole team. Because again, how to not be judgmental and how to not act surprised or shocked or anything. And I think that's really important to remember.
How about the families? Is there education for them?
I,
Thought of them?
I think that's really important. The family, in this case, they were pretty good families. I've had some more challenging situations in the past, especially in the nursing home setting, where I think it becomes even a bigger issue because everything has to be care planned, and even sexual activity in a nursing home, if somebody's interested, becomes a whole team. It becomes a whole team effort process. And families, it's really hard because some people really believe those myths that, I think their parents had sex. However many kids they had, that's how many times they had sex. They had sex never again after that. So I think you have to, and it's interesting because even as people the parents are in their 80s and the children might be in their 60s. They still kind of maintain that with their parents, like, no way, they're not. They don't have an interest. And so there is a lot of education about this is a part of life. It continues throughout the lifespan. And what can we do to honor your loved one's wishes and that this is an important part of their life and how can we help them continue that? So some final recommendations to everyone, be open-minded. I'd say practice these conversations, which means talk about sex, have them more often, talk to your clients or patients that you work with, get background information, right? We've talked about lots of things, whether it's medical background, whether it's medications, whether it's their activity lifestyle choices, whether it's their psychosocial things. Have they had big changes? I think it's really important to talk about all those, figure out what matters most, what's important to them. And then we want to help patients achieve those wishes if it's possible in the safest way that we can. And lastly, educate about safer practices regarding sex. I think those are important things to remember.
All right. Any final comments or questions before we transition to the Kentucky Coalition for Healthy Communities? Let me check the chat.
I did have a question. What about like domestic violence and new partners and educating them on the internet and the predators and all that fun stuff?
It's a really good point. So I will, um, we could do an all-day session on older adult sexuality. I'll tell you that. Um, I have found that, you see more older adults because of how difficult it is to find people actually doing online dating. So if somebody comes to you and says they have a new partner, well, how did you meet? I mean, this is like a normal conversation, right? How did you meet? No, if online, well, have you met them yet? What does that look like? Sometimes people say, well, I'm going to go meet someone. Well, we want to talk about we should meet them in public. We should get to know them first before we go and book a hotel room, right? I think those are things to talk about. Then it becomes, if that's the conversation, what about safer sex? Have we had STD panels? Have we checked for HIV before we're having sex with a new partner? The same things we would talk about with older people. It's really important, for domestic violence and abuse. I mean, again, I think that needs to be in the back of our minds with all people we interact with because you never know and people don't talk about it. And I know a lot of health systems now ask, do you feel safe at home? Do you feel safe in your relationship? But I think it's more just getting that more detailed psychosocial history to learn about what else might be going on and just have it in the back of your mind. You never know. I mean, I've heard so many cases that I wouldn't expect, whether it's in a facility or in a home and so you just have to just keep it on your radar screen. I think that's really important. And Kara, I think, Pam, this said, I believe there's a level of fear when it comes to possible legal ramifications. And there is, but a lot of people in medicine, I think it's really important to talk about. People are scared of a lot of things in medicine. I mean, sexuality just has its own stigmas, unfortunately. There's legal concerns with everything we do. And I think it's just, documenting, being thorough, again, is all important ways that we protect ourselves.
And then Justine put the link in the chat. Thank you, Justine, for the PALT Med capacity. Thank you so much for sharing that. And then I think Karen has a question. Karen, if you'd like to unmute.
Yes, let's see.
Oh, you unmuted for a minute.
Yes, we heard
you.
How about now? Is this better?
That's better.
All right, I'm Karen Krieger, and I just wanted to share a couple of points. I've had patients' families make appointments in the name of the patient to discuss their parents' sexual activity without the knowledge of the patient. And that's something that we have to be aware of when people show up in our room under a patient's name, whether they have the ability to speak to that. And secondly, giving information kinetically having models to demonstrate how you use a female condom, dental dams, and what things are out there. Older women may not have that knowledge, that they have the freedom of providing those condoms and that they can be inserted hours early before the use. So we have to be prepared as clinicians, not only to bring up the topic, but to teach them the safer sex techniques. So thank you for letting me share that.
Well,
Thank you.
thank you, Karen. That was really helpful.
All right. Let's see. Any final comments or questions?
Thank you so much, Dr. Morton.
Well,
Yes.
thank you all for your participation. It was great. I'm happy to have such a good interactive crowd today.
I'm just going to give a short plug. If you would like to access any of the session material, the PowerPoint and the session recording will be in iEcho later today. When you log in, they've updated their system now. So when you log in to iEcho, when you see today's session and you see session details, if you click on view details, that should open up a screen that allows you to view the recording and download the materials.
All right. Go for it, Mona.
Yeah, I think my job's harder than Dr. Laura's because now we got to figure out how we're going to get this information to the community. In my earlier life, I actually taught sex education through the schools, through the health department. And then people would say, well, how can you do that? And of course, at that time, I was still old enough to be a lot of their grandmas. And I said, we just talk about the facts. We make it real. And of course, I was trying to teach our young people how important it was to make good choices in all of life. We talked about sex, we talked about alcohol, drugs, and all that kind of stuff. But I have to admit, I'm not quite as comfortable as talking to seniors about it as I was them, but I do have to admit I was awful nervous when I first started with them. So now I guess I can learn how to do this, and I hope that the rest of us can too. And of course, I am one of those seniors that have been in a doctor's office, and the question has been asked, are you sexually active? And I would say no, but there's one thing I noticed, and this may be something for us to take note of. They never asked me why. Now I would say I'm a widow and it's my faith that would keep me from being. But at that time, my husband was having a problem he didn't want to talk about. So, maybe even with those types of conversations. But let's go on with my slides here so you can understand who we are, the Kentucky Coalition for Healthy Communities. And it's what we want to do is to train and empower stakeholders and community members to provide hope and education for their communities. And what is more important than what matters? And sex is an important part of life, whether you are 17 or you are 77. So we need to be able to know how to talk to people about it. So let's go on. So what I feel that knowledge sharing is caring. So as we learn how to talk to our community about this, we will show them that we care for them. Now, I really do believe there should be some education, some role playing in this kind of thing so that we actually know what we're doing. And perhaps our social workers get those kind of things, but even us as community health workers, I think that's something that we need to look at. How can we really talk to our people about it? So if somebody would just quickly say, what's something important that you learned today, and how will you share this information with your community? If you know. And if you don't know how you're going to share it, then I guess we made my point that we really need to figure out how to do this. Just unmute and speak, or Justin will be watching the chat. Honestly, that sex is important at any age, yes. Whoops. Go ahead, Justin. It goes too fast for me.
The considerations for legal and medical concerns.
Yeah, and there was one right before that I missed. It was on just for a second and went off.
It said this is new information, so thank you so much.
Okay, okay. Sex is a normal part of life at every age. I learned that whoops, let me quit. You just go ahead.
Okay, I learned that I am 63 and there's hope for me and my husband in the future. LOL. I think that what you said, we need to ask why sometimes.
Mhm. So, how are we going to share this with our community? What are we going to do? Has anyone got any ideas?
Well, I remember, and I think I've told Pam this. Somebody said talk to our families and friends, but I told Pam this story one time that when I was first working for the Traeger Institute, somebody was doing a health intake. They were doing a case presentation and they got to sexual health, and they said the person's single, so they don't have any sexual health issues, concerns. And it's like I was a little too immature in my thinking to stop and be like, uh, you should rethink that. But I mean,
Mhm.
things like that, when you hear these kinds of
Mhm.
stigmas or these
Yeah.
kinds of stereotypes addressing it, somebody chimed in that they talked to their family and friends. Heather chimed in, be more open-minded to older adults' needs and preferences.
Mhm. Okay. This,
I once did a session for parents of HIV positive adults, and we had snacks like a reception before we started, and I had created condom roses as part of the decoration. And someone came to me and said, "What are these?" And I said, "These are condom roses." And I explained what they were and how they worked. And by the end of the session, all of my roses were gone. And there were none of the children there. They were all parents. These were seniors that had come to support their kids. So having those knowledge sharing activities and having things that are out there for them to see and ask questions about is important for them to break the ice.
okay. Thank you so much. And that's what I'm wanting to hear, that we're going to have some type of knowledge sharing. And I guess I'll put Dr. Laura on the spot. Do you know people throughout the state who are equipped to be able to help us with that? I know you can't go everywhere with all the other responsibilities you have.
That's the tricky thing. There is not a lot of us who are comfortable
Mhm.
having the conversation. Again, that's why I'm happy and enjoy doing these educational experiences because there's not enough of us to have these conversations. And
Mhm.
how do we educate others? So no, I don't actually, which is unfortunate because, and if
Okay.
anybody has any connections, please introduce me. I am happy to make new colleagues and friends. So if any of you out in the state, please connect us.
And may I say, if any of you know someone that you could send that information to Laura, and maybe they could come up with a educational workshop that we could attend, and then we become a part of that army out in our communities. Because that's how we're going to get our community safe, is when we all take a piece of it. We can't expect someone like Dr. Laura to do it all. And so that's kind of what we're about in the KCHC and the Traeger mission, is to educate others so they can educate others, and on we go. So I hope that that's something that we really look at. Let's go to the next slide, Justin. Okay, so I'd like to give you all a chance to share anything that's going on into your community, whether you have a special event coming up that you would like to invite us to, or if you have a concern that perhaps we could help you with. Everybody's fine? No events to talk about?
I'm putting in the chat the Louisville Metro Summer Concert Series. They offer concerts in the one I think Thursday a month, and they offer I think ice cream for people 55 plus. So it should be a fun series.
Thank you. Thank you. Anyone else? Okay, thank you for that information, Justin. Okay, so let's go on to the next slide. So I happen to have some things to talk to you about. We have My Health Matters, and so does yours. That's something that we do just about every Monday night, of course, not on a holiday, from 6:30 to 7:30. It is Eastern Standard Time, and it's by Zoom. And everyone is welcome. There's no age, there's no territory or anything like that. And anyone that just wants to come, it is 1 hour long. We do not go over the 1 hour. We start pretty promptly at 6:30. Sometimes we'll wait a couple minutes for those that are running in from work. But the idea of this is a time for us to come and learn a little bit about different topics and then have a time to talk about it and discuss it. We actually started this during COVID to kind of alleviate some of the loneliness and isolation. And when COVID was over with, I thought that we probably would go to once a month with Zoom and then once a month in person, which I had done before. And our participants said, oh no, we love it just the way it is. So we've been doing it all this time. Also, if anyone's interested in being a speaker, we're always looking for speakers. So as you can see, we're going to be having our own Heather Shaw talk to us this coming Monday night. And she's going to talk to us now. If I understand this is the tick disease from people being bitten by a tick. And so I think that's something that all of us need to know more about, the symptoms, and then if we get at the management. Of course, the following week is Memorial Day, and I certainly hope that everyone has a beautiful weekend. On June 1st, just on occasion, maybe every 6 to 8 weeks or so, we do an open conversation, and we give our participants a chance just to talk about what's on their mind. And sometimes we have, well, not sometimes, all the time, we have some really great conversations. And it just gives us a sense of belonging and community. On June 8th, we're going to be hearing from our own Dr. Anna Fall about thriving after cancer and how she has been able to apply these 6 pillars of lifestyle medicine to help her stay in remission. And the next week, we'll have our Riley Banks, who will do bird watching. And then June 22nd, we're going to have Dr. Moisa. And if you've not met him, he's a delight as well. And he'll talk to us about men's health. And then the following week, we have one of my very best friends. My soul sister really is who she is, Barbara Gordon. And she's going to be doing PTSD and older adults. So as you can see, it's going to be very good speakers and very good topics. And I hope that all of you will think that you would like to come or invite someone to that. Let's crash Zoom that night. Let's have so many people. What do you think? Okay, so let's go on to the next one. And we are right now running a couple of diabetes self-management programs, and we will be starting some more in the summer. We just don't have our dates together yet. We've been really busy with some other things. But this is a free 6-week science-based program to help you manage your diabetes or your pre-diabetes. We also welcome those who are caring for someone and does the cooking and the shopping to join us. And of course, these are done by Zoom as well, although we do them in assisted livings, different places like that in person. So if you know someone or you as an individual would like to take this class, you can see where there's the interest survey, or you can call this number and we will get you on our list. Next slide. Okay, so we have also Flourishing Together, and we named it for this year, New Hope, Let's Get Healthier Together. And we are seeing some folks in our classes that are really doing that. We have a couple of wonderful classes. We will be starting some more soon, but again, we're trying to finish up our year and get that done, and then we'll face another year. This is open to anybody. There's no age restrictions. Some of the best classes have been 3 generations. And we help people learn some really easy and practical ways to become healthier, to become more active, and to learn how to manage and prevent chronic disease in a very safe and encouraging social environment. So if you're interested in that, you can get a hold of us. Also, if you're interested in becoming a facilitator, I would be glad to talk to you about that. Just as I said about the other things with Dr. Laura. Traeger can't do everything. We don't have enough facilitators to get it everywhere we'd like it throughout the state. So wherever you may be from, if you think, wow, that sounds like something I'm interested in, I would suggest you take the class so you can just see exactly what it is and then become a facilitator. Okay, let's go on to the next one. And there's many other programs besides what I have up here, but these are some programs that we just want you to know about with Traeger. Of course, the Flourish program is what we very first started with, that we had the idea, and I say we, it wasn't really me, but Dr. Fall, Dr. Christian, Barbara, some of those had worked together for a while, and they wanted to be able to come up with a way to help adults with multiple chronic conditions to improve life satisfaction through a comprehensive care navigation program. And that's what we do at Traeger. We have a lot of different disciplines there. We are able to work with our learners, social work learners, as well as our community health workers, and we're just able to really help our patients in a way that is just unbelievable, really, how we can help them get the resources they need and go where they need to go. Our caregiver program is designed for those that are taking care of aging adults that are 60 and above to provide the support and resources they need. And we just need to be really conscious of our caregivers. They have a hard job, and we don't want our caregivers to burn out and become ill themselves. So we want to help them as much as we can. And there is an interest survey there. Virtual friendly visitor program. This is another one that is to help those who are lonely, isolated, and we train our learners, as well as we have other folks that do it, to be able to call and talk to these people once a week, every other week, whatever they need. Of course, there is an assessment done. If somebody needs more help, they know how to refer. And our Pearls program is it's a way for our people to help them rediscover their joy and their purpose. A lot of people, you'll say, what really matters to you? And that has to kind of be dug out because they don't know. And so this is going to help them connect with that and be able to live a more healthier life. This is a no-cost counseling program for adults that are 60 and over. Now, again, they too have an assessment and can refer if they need to. So let's go on to the next slide. Okay, I'm going to turn that over to, I believe, Justin.
Okay, so we have our Optimal Aging Scholar Program, and we have our Primary Care Behavioral Health Scholar Program. The Optimal Aging Scholar Program is for healthcare learners enrolled in higher education institutions, faculty, preceptors of higher education, and professionals across the healthcare field. This is really a deep dive into age-friendly healthcare principles. You can reach out to Sophia Banks, and she can let you know more about becoming an Optimal Aging Scholar. And then our Integrated Primary Care Behavioral Health Scholar Program is for behavioral health interns who've completed the program components, or interprofessional healthcare professionals participating in primary care and behavioral health learning activities across primary care settings. So we have these two scholar programs, again, that take a really deep dive into age-friendly healthcare principles, and we really, get you engaged in lots of different learning activities. And then our conference in next spring. So if you're interested in either of those programs, the contact information will be in the PowerPoints, or you can also email me and I'll connect you to the appropriate coordinator. I also want to let you know about our Flourish Care Centers of Excellence. We are partnering in 3 area agencies on aging around Kentucky to really supports aging and independent living, and we work with organizations to eliminate barriers to transitions of care for older adults. So we offer monthly meetings in each of those areas. So the KIPTA area, the Cumberland Valley Area Development District, and the Barren River Area Development District, to really create community there to help with older adults. So the contact information will be in the PowerPoints, and you can contact Riley, Chandler, or Heather. But again, if you ever have any comments or questions about any of these programs, you can always reach out to me as well.
Okay, so this is our pledge. And I hope that each of you will think about this and ask yourself, where is my place in this? So as a Kentucky Coalition for Healthy Community member, we will become an effective state coalition working with community members and community-based organizations to empower our state to become a healthier and compassionate people. Therefore, we will practice self-care and model healthy behaviors to our families, our co-workers, and members of our communities. And if you want to learn how to do that, please join one of our Flourishing Together classes. That's what it's all about. How can we take care of ourselves? And then how can we take that health and make it contagious in our communities? Okay.
Thank you, Mona. So again, thank you so much, Dr. Morton. This was a really illuminating conversation. Hope you will join us on June 12th for Nutrition and Social Connection, the Power of Shared Meals. And then we're going to have, we're going to close out this series with a presentation on urinary incontinence. Dr. Kellen Choi is going to present comprehensive management of complex voiding dysfunction. And I am going to reach out to her and ask for a way to say that everybody understands, but I just know that it's about urinary incontinence. So we hope to see you at future sessions. This is the session evaluation. I'm going to stop sharing just for a second so I can get the link. So you can either use the QR code or you can access the link that will be in the chats. We so appreciate you being here. We hope you will evaluate today's session, and we hope to see you in the future. So here is the session evaluation, and thank you so much for being here today. I'm going to stop recording.